This conference will now be recorded.
Hematology. This is an important subject for exam. We are going to get many questions from here. Basically, they would like to ask you about the blood cell, different blood groups, why they are important, and what is their significance, which these can be blood products can be used for blood transfusion, and then what are the complications of blood transfusion. You must have seen the questions very frequently that they like to know about complications of massive blood transfusion, and what will happen, how the body will respond, and how you can fix these issues. So all of these points are very important, so they can ask you about these. Then coagulation mechanism, VTE, how the clot will form, what will happen in DIC, and then you should know about different reagents. You should know about different types of hemoglobins. So hemoglobin, actually, this is one subject that you cannot just cram it up. You should have good knowledge. You should have good basic concept. Only then you can develop your knowledge. Okay? These are important things for you. So let's start that. What is it all about? So if we go to the definition of hematology, what is that? Hematology is the study of blood and disorders of blood and complications and their management. So what type of tissue is blood? People will say that it's a fluid. No, it's not a fluid. Blood is a connective tissue in fluid form. In human bodies, blood makes up 7% of the body weight. Blood contains the blood cells that are called formed elements and the liquid portion that is known as the plasma. So basically we have three types of cells which are present in the blood, and you know about them. These are RBCs or erythrocytes, then WBCs or leukocytes, and then the platelets or thrombocytes. Blood volume, it forms a lower percentage of body weight in the fat person as compared to the thin person. So that's why the obese person, you can say that they are anemic also, okay, because their blood volume is already less. Blood volume, it can be calculated by the simple formula that blood volume is equal to, you should know about this formula, that blood volume is equal to plasma volume divided by 1 minus hematocrit. Let's say that hematocrit of one person is like 0.45. So you will just calculate and you will see that the answer is going to be the plasma volume, whatever you have, and then 1 minus hematocrit, and you are going to get the blood volume like that. Coming to the blood cells, but usually, they will not ask you to calculate the blood volume, but if they do, then this is the simplest formula to calculate the blood, that the blood volume like that. So the type of cells, the RBCs, if we will summarize them, we can say that, these RBCs, they are biconcave discs. As you can see here, they are biconcave, and they have the diameter of 7 microns, and at their edges, they have a thickness of 1 to 2 microns. If we talk about their volume, their number in the cell, we can say in the body, we can say that in the male, the level is 4.5 to 6.5 into 10 raised to power 12. This is the number in the females. And if we talk about the females, the erythrocyte count, it is going to be like 4 to 5.5 into 10 raised to power 12 per liter. And they make up 40 to 54% of the blood in the males, and in the female, the hematocrit is going to be 34 to 47. That is considered the normal hematocrit. So the RBCs, what is their function? They carry oxygen to the tissues and they carry carbon dioxide to the lungs. They don't have the nucleus, and they lack organelles. They are biconcave with a large surface area to the volume ratio because of for rapid gas exchange. So the surface area should be larger. Their average lifespan is 120 days, and the source of energy is glucose. 90% is used in the glycolysis, and 10% is used in the hexose monophosphate shunt. So the membranes, they contain chloride and the bicarbonate antiporter system, which will allow RBCs to export bicarbonate and transport carbon dioxide from the periphery to the lungs for elimination. That is the basic purpose of circulation like that. Erythro means red and the site means cells. Erythrocytosis, it means that the number of the RBCs has increased, like you will see in cases of polycythemia, so high hematocrit. Anisocytosis, it means that the RBCs are of different shapes. Some are like they have their surface is irregular, some are like pointed, and some are like elongated. Uh, Poikilocytosis means that they have different shapes. Anisocytosis means that they have various sizes, small, large, and they can be medium size, they can be of any size. Whenever they say the word pylo, it means it is about the shape. So poikilocytosis means that they have different shapes. Like in some cases, they are broken down, or like you will see different pictures in different cancers or in the bleeding disorders. Reticulocytes, these are the immature RBCs, and they reflect erythroid proliferation. Erythroid is the precursor cell which will ultimately give rise to the RBCs. So they can have like blue color polychromasia on right in the stain of the reticulocytes. It represents residual ribosomal RNA. RBCs in the human beings, they are non-nucleated, as I told you, and due to the absence of the nucleus in the human RBCs, the DNA as well as the organelles such as mitochondria and the Golgi apparatus, they are absent in the RBCs. That's why I said that they don't have organelles. So due to the absence of mitochondria, the energy in the RBCs is produced from the glycolytic process. Red cell, red cell doesn't have insulin receptors, and the glucose uptake by the RBCs is not controlled by insulin. Normal red cells, they appear approximately 7 microns in the diameter, and they become bullet shaped as they will pass through the capillaries, and the capillaries, they will have a diameter of 5 or 6 microns. RBCs are the blood component which is most frequently used for blood transfusion. The normal erythrocyte lifespan is 16 to 18 weeks or 120 days, and breakdown of erythrocytes, it takes place in the reticuloendothelial system. Breakdown will yield iron, and then this iron is recirculated, reabsorbed for further use. At the time of RBC's breakdown, hemoglobin is released and it is degraded into the globin part and into the iron part and porphyrin. Erythrocyte breakdown, it will also yield bilirubin that is carried by the plasma protein to the liver. So hematocrit value, I have told you that reticulocytes, they will be formed, and then after 1 to 2 days they will be released into the circulation. And reticulocytes, they can have like small amount of basophilic material like Golgi apparatus and some mitochondria and ribosomal RNA, and they will be able to synthesize hemoglobin. And once they will mature, then they will be released into the circulation. Production of RBCs, it is stimulated by tissue hypoxia, by high altitude, anemia, and also by erythropoietin. So hematocrit value, so hematocrits. We can say that hematocrit or the packed cells, they can be defined as the volume percentage of the RBCs in the blood, that how many RBCs are present in the cell in the body of a person. So hematocrit, it can be obtained by centrifugation of the blood because the RBCs, they are heavier than the plasma, so they will settle down. Hematocrit, it may also be calculated by multiplying the mean cell volume by the RBCs count. However, it will yield a slightly lower than the actual value as compared to the centrifugation because a little amount of plasma is trapped between the cells during the centrifugation. So if I will tell you that what is the mean cell volume? Mean cell volume, how do we represent it? We write down MCV. So mean cell volume, that is equal to uh, 79 to 96. 79 to 96, and that is FL. Okay. It means, what does it mean? It means that, so that is 79 to 96, that is considered the normal. If it is less than 70, then you will say that this person has microcytic anemia. Like less than 79, you will say that this is microcytic anemia. If it is more than 96, then you will say that this person has megaloblastic anemia, or the cells are going to be large. Then another important concept is that what is mean cell hemoglobin. So that is equal to, like, what is its concentration? That is 30 to 36. 30 to 36 grams per deciliter. Remember, now we are mentioning in the deciliters like that. Then another point is that that is the mean cell hemoglobin concentration. You must have seen that they will give you the patient that what is the defect in that person. So just remember, the mean cell hemoglobin concentration is this much. And if they ask you about the mean cell hemoglobin, any one of you, what is that level? Mean cell hemoglobin, it is referred to as between 27 to 32 picograms. That is the amount of hemoglobin that is contained inside the cells like that. So then you should be familiar with another important concept that is called ESR. So what is the ESR? ESR can be defined as the rate at which the RBCs they will sediment in 1 hour. Sediment like they will settle down, okay, in a column of blood. Like you will take the blood in a test tube, and then you will see that how many of them they will settle down in 1 hour. Like that. That is the point. So this is ESR. This is a measure of the acute phase response. ESR can be raised or it can be reduced. Increased ESR, what you will see when the large cells are present, and then the lower amount of cells is there, then more proteins like the inflammatory disease processes such as rheumatoid arthritis, systemic lupus erythematosus, polymyalgia rheumatica, then in malignancies. So ESR, it increases with age. Roughly, ESR is equal to half of the age. Like if a person is like 60, then we can roughly say that his ESR will be 30. ESR also tends to be higher in the females. So reduced ESR, when are we going to see it? These include dysfibrinogenemia. There is less fibrin into the blood. Then hypogammaglobulinemia. Then patient has this low molecular weight dextron, it was given for something. Then reduced ESR in polycythemia vera. Like the number of the cells is very high, too numerous, so they will not settle down. Remember, people think in polycythemia, since the number is very high, so the ESR will increase. No, ESR is the rate of settling down of the RBCs, so it will decrease in this condition. In secondary conditions, like which have like abnormal RBCs, like in cases of sickle cell anemia, hereditary spherocytosis, acanthocytosis, then like corns on the surface of the RBCs, then in microcytosis. Like there is hemoglobin disease, there is iron deficiency, then they will produce an artifactual decrease in the ESR. That it will not be reflect the actual picture, but apparently it will be good. Then in cases of hypofibrinogenemia, like dysfibrinogenemia, there is no fibrinogen in the system. Hypofibrinogenemia, when it is less than the normal expected level. At least it should be 2. If it is less than that, you will say this is hypofibrinogenemia. We are going to see it in certain conditions, like in disseminated intravascular coagulation. Then if the patient has massive hepatic necrosis, then excessive anticoagulation has been done, then high WBC count in cachexia and also in the heart failure. So in ESR, it will also increase, like we have seen that in most of these conditions. Then additional conditions can be, it will increase in sepsis, Then it can increase if there is ischemia, okay, and it can also increase if there is some trauma to the body. In response to the trauma, it will increase, okay. And then the immunological disorders and the malignancy we have talked about them. There is a protein called C-reactive protein. C-reactive protein is a protein, we can say that this is an acute phase reactant, this CRP. That's also an important issue. What does it do in the body? So the diagnostic value and the stuff is not, and the things are not important. But the point is that C-reactive protein, why it is important. Okay. Can you tell me about it?
It is produced by the liver in response to inflammation.
Yeah, it is produced by the liver
Yeah.
in response to injury, right? And this is an acute phase reactant. Acute phase reactant, what do you understand by that? Some injury, some insult has taken place in the body, so it is produced quickly, okay? And it can rise within 6 hours. That is the point. It will rise within 6 hours. So this is in the acute phase of the trauma. Then the point is that it will follow clinical, so it can also follow the clinical state of the patient. If this CRP is elevated, it will tell you that some inflammatory process is going on. And it is the benefit of this one is that the ESR, what is the benefit of using this CRP? For ESR, it depends upon the hemoglobin concentration, but this is not dependent on hemoglobin concentration in the body. That is the point. So that's why it is going to show you the actual picture. Then you should know that it is less helpful if there is chronic inflammatory response, because in chronic conditions it will be elevated. So it is not very useful in chronic conditions. Why? Because it is going to be elevated anyhow in them. So it will not be helpful in that. Then the question is that if the level is very high, it may indicate that there is some future disease like that. So that is the point. So if we talk about the erythropoiesis, erythropoiesis, it develops in the fetus between 3 to 8 weeks of, and different organs, they will take up this function. And as the period of gestation will increase, then different organs, they are going to take up this action. Yolk sac is the first organ to form blood, and it will start forming blood within 3 to 8 weeks of life. Then liver, it will take up this function from 6 weeks till birth. Spleen is actively forming blood between 10 to 28 weeks, and bone marrow, it will start working in by 18 weeks, and it will continue into the adult. That is the point. Regarding hemoglobin development, hemoglobin, if you will look at the fetus, so what type of embryonic hemoglobin you are going to see?
Hemoglobin F.
Hemoglobin F, but what will be in the chain? Just remember, this will be their configuration, the epsilon chains and like these chains, okay? So that if you see that composition, you will say that this is embryonic globin, because anyhow you're not going to see that in your this adult life or in the once the baby is born. Fetal hemoglobin, 2 alpha 2 and gamma 2. These compositions I want you to remember very well, because they are going to ask you about these things in the exam. Adult hemoglobin or adult hemoglobin A1, 2 alpha chains and 2 beta chains. Hemoglobin F or the fetal hemoglobin, that is 2 alpha and 2 gamma chains. They have like high affinity for oxygen due to less avidly binding of the 2,3-biphosphoglycerate, and it is not bound very tightly. So what will happen? Hemoglobin, fetal hemoglobin, it will be allowed to extract oxygen from the maternal hemoglobin. So maternal hemoglobin can be hemoglobin A1 and hemoglobin A2, and then it can be taken across the placenta. If you will look at hemoglobin A2, hemoglobin A1 is alpha 2 and beta 2, and here you have alpha 2 and gamma 2. This is a form of adult hemoglobin which is present in small amounts, but that is like very less, so it is not going to affect anyone. Then the fetal hemoglobin, it has high affinity for oxygen because it is not binding to the 2,3 biphosphoglycerate very tightly. So what will happen? This is the fetus, and this is the neonatal period, postnatal period, and then it is the adulthood. So the sites of blood formation you have seen 3 to 8 weeks. This is going to be the yolk sac. Liver will take up this function at how many weeks? From 6 weeks till the adult life, it is going to do this function. Spleen will also take up this function, and spleen is going to continue this function from 10 weeks to the 28 weeks. And then you will look at the bone marrow. Then in the adult, the main tissue of producing blood is bone marrow. In the embryonic period, you are going to see the embryonic hemoglobin. It will continue here, then it will increase, and then it will give rise to the adult hemoglobin. Because now the person is born, so it will be adult hemoglobin. Fetal hemoglobin level, you can see that these are the months, these are the weeks, and these are the months. Fetal hemoglobin, initially its level is less, and these are the gamma chains, okay? They are present in the fetal blood. And the beta chains, they are present in the fetal blood in the embryonic period, and then they will transform when they will start forming these beta chains. You can see these epsilon and these S sigma chains, but by the time of 36 weeks, this shift will occur. Between 30 to 36 weeks, it will change to beta type, to the adult type. And the fetal hemoglobin, it will have like this alpha everyone has, A alpha everyone has, and then this gamma subunit, it will rise gradually. By 6 weeks, it will continue to rise, and then now on from 6 week onwards it will stay at a stable level, and then by 30 weeks of pregnancy its level will start declining. And regarding the alpha chains, you are going to see them that they will also start forming in the 5th week of the life, and then their level will rise, and then after reaching a significant value that is by 18 weeks, the fetus is going to form the alpha chains like that. Okay? So you can appreciate that these are the changes. This picture should be in your mind. So that is how the hemoglobin will change. So can you tell me something about erythropoietin? What is the role of erythropoietin? So erythropoietin, this is a glycoprotein hormone which is produced mainly by the kidneys, and this is produced in very small amounts from the liver also. And erythropoietin production is also stimulated by hypoxia. Why hypoxia? Because there is less oxygen, so we need to produce it. Okay, that is also a very important type of protein which is responsible involved in the blood production. So it is coming from which areas? It is coming from the kidney and I
Liver.
just told you very less amount of liver. Okay, you don't
Yes.
forget.
Can
Very
use
less.
for also for end-stage renal disease. Have anemia also. Am I
Yeah.
right?
Yes, but in anemia in end stage renal disease. Okay.
Yes, and end
So
stage. Yeah.
so not in regular anemia. If your patient has anemia secondary to the renal disease, then you will give it. So it will stimulate RBC's production by stimulating the formation of pro-erythroblast, and it will cause an increase in the level of the reticulocyte. So these are the basic things that it is going to increase reticulocytes. The uses we will talk about them later. That is the point. That is the benefit of this protein. Now regarding the plasma, how much of the plasma is present in a human body? We just talked about that.
40%.
Yeah. So
40%.
can more 40% will be cells, 45% will be cells, and 50% will be plasma. So if you take bloods and you take out all cells, which are the cells like the RBCs, WBCs, and platelets, then what you are going to get, that is plasma. So that is the simple equation. That's how you can remember that. So plasma is not the full blood. Just remember, plasma will make up 58 to 62% of the blood volume. How much? 58 to 62% of the blood volume. So you know that's why you have to have very accurate information. It will make a of the not blood of total blood volume. You have to be very specific. Total blood volume. So the 58 to 62% will be plasma and others will be cells. So it contains proteins. Can you tell me which proteins are contained here? Albumin and globulin and what else? I just told you in plasma, what do we get in the plasma? Clotting factor. So it will contain fibrinogen also. Okay, these are simple questions. They are going to test you on them. Fibrinogen will be there. So if we talk about the globulins, then you know that globulins, they can be alpha and beta globulins, okay, and which are transported by the gamma globulins and the which are basically gamma globulins. What are they? Come on, you know about that. Antibodies, okay, alpha and the beta, and which are carried as the antibodies because all antibodies are present in the plasma. That is the point. So then synthesis of hemoglobin. So where the synthesis of hemoglobin will take place? In the mitochondria of developing cells. We said that the mature RBCs, they will not have any mature RBCs, they will not have mitochondria. Okay, so when the cells are developing at that time, mitochondria of the developing cells, they will form the hemoglobin. So when the hemoglobin is forming, then vitamin B6 is very important and it is the rate limiting step for the synthesis of hemoglobin. And why it is required? It is required for conversion of glycine and succinic acid to delta amino levulonic acid. Protoporphyrins, they are also formed and the iron is inserted to form the heme and that's how it will be inserted into the globin chains. So adult hemoglobin, it has two alpha and two beta chains and it is going to make up like 97% of the whole hemoglobin. So adult hemoglobin, that is equal to 97%. That is the main hemoglobin in the adult. 97% of the total hemoglobin. Hemoglobin 2, it will have like two alpha and two gamma chains. Okay. So hemoglobin A1, it will be like how much, like 1 to 3% you can say that. Okay. And fetal hemoglobin, it can be found in the adult, but it will be less than 1%. So that's why these numbers are important. So if your patient has hemoglobin A2 is going to be there anyway, right? So this is equal to like 1 to 1, not 1, we can say that 1.5 to 3%. I want you to remember these numbers because you know they can ask you in the exam. That is the point. So after that, regarding metabolism of iron, why this metabolism is important? Because the RBCs are continuously broken down into the body, right? So when they will break, what will happen? We are going to get iron and we are going to get the myoglobin, okay? And we have just read that this iron, it will be transported back to the liver and where what will happen? It will form hemoglobin. So the iron and the myoglobin, they are transported in plasma and as transferring and they can be taken as the, if we have excessive erythropoietin, excessive this ferritin, it will be excessive iron in the body, it will be stored as ferritin. So ferritin is going to, that is the storage form of the iron in the body. So hemosiderin, this is a very insoluble iron which is stored only formed in the iron overload. In a normal person, you are not going to see the hemosiderin. So as you know that every single day we are losing iron from the body. How we are losing? Like some of it is going into the feces. So, but usually it is less than 1 milligram in the male and 2 milligram iron is lost from the female every single day. And the children and the growing children, pregnant women, they will need more iron because they need to form more blood. So if someone is taking like daily 15 to 20 milligrams of iron, then zero point 0.5 to 2 milligram that is absorbed. So daily how much we are absorbing? Just less than, we can say that 10% of the iron is absorbed into the system every single day. So that's why most of the iron, like 90%, it will be wasted also. So how do we absorb iron from the body? So iron will be absorbed from the body by phytates, phosphates, and the bicarbonates. And these are the, then iron absorption. This is promoted by vitamin C and hydrochloric acid. So hydrochloric acid, hydrochloride ions, they will make the iron more soluble, and ascorbic acid or vitamin C, it will reduce the iron to ferrous form, from ferric to ferrous form. So which is less likely to form the insoluble complexes. That is the reason that why we ask the patient to take the vitamin C or the orange juice with the this iron, because now the patient will form Fe plus 2 plus. In Fe2 plus form, the ferrous form, the iron is absorbed. If it is iron in the third form, like the 3 valency, like Fe3 plus, then it will be insoluble. That is the point. Okay? So following absorption, ferrous ions, which is 2 plus, it will be converted to F3 and it will be bound to the ferritin while they are in the intestinal cells, and then it will be taken back to the plasma where it is bound to the transferrin protein, which is a beta protein, and that is synthesized in the liver. And the transferrin saturation in a normal hemoglobin carrying person, it is 33%. So then each transferrin molecule, it will bind to 2 atoms of the ferric oil. Transferrin, this is here the blood iron which is bound to the transferrin. Transferrin, remember, transferrin is just the transport protein. Storage form is ferritin. Don't confuse them in the exam. Don't worry, these all notes are written and they are available on the web page. So the iron which is bound to the transferrin, it will become attached to the specific receptors on the white cells and reticulocytes, and then iron is removed. So iron is stored in the ferritin form and in the gut epithelium, and when the gut epithelial cells are lost, then the iron is also lost. Hemosiderin, this is an insoluble iron protein which is found in the macrophages, hepatocytes, and spleen, but that is not active. That iron cannot be used in forming hemoglobin. So most of the iron is absorbed in the duodenum and the jejunum, and it is carried, how it is absorbed, by carrier mediated transport. These things are important. So ileum is not involved in absorption of the iron, but the duodenum and the jejunum, they are involved. Iron deficiency, it will result in increased GIT absorption, and this will be effective within 3-4 days. So the serum iron concentration, it is like 11 to 30 micromoles, and the concentration can be higher in the morning as compared to the evening. In the body, if it has plenty of iron, like the more RBCs are broken down, then these cannot be excreted from the body. That's why what will happen, excessive iron, it will be deposited into the cells. So the body cannot remove these cells on its own. So what will happen? We will have to give them chelating agents. These chelating agents, they are going to remove the iron from the body. They will make it more soluble and they will take it out of the body. Is this concept clear? That if there is plenty of iron, then we need to remove it by chelating agents. And the important chelating agents, if I will tell you, these are like despiroxamine, defricerox, defriperanone. All of these are removing agents, and then you will see them when they have like we are giving them in the patients who have like. Can you tell me where do we give these chelating agents? Sickle cell disease, you will give hydroxyurea. In thalassemia. In thalassemia we have. You remember? So regarding the blood groups, why it is important for you to know about the blood groups. Blood groups are very important because because of some certain antigens, the blood is going to have certain characteristics, and these are important because each of them, it is telling you about the genetic makeup. So for us, the significance is that we have to give the blood which is group compatible. So we use basically two systems of classification, like ABO blood group, like a person can have group A, group B, and group O. And the second type of classification is that we will look for the rhesus vector. Rhesus vector, it can be Rh positive or it can be Rh negative. That is the point. Okay? And so that is also important for you. So if I talk about the blood groups, then I will tell you that this classification system, like I said, ABO and the Rh classification. So it depends that what type of allelic gene is there. So basically capital H and small h, these two genes are carried and they will carry allelic genes. A, B and O, these are allelic genes. They are alleles of the genes. A, B and H antigens, they have very similar structure and they have differences in the sugar, and it will determine their specificity. The H gene is present, it codes for enzyme H, which attaches, this fruit. It will attach glucose to the basic glycoprotein to form the H substance. And this H substance, that is a substance H, it is precursor of A, B or O antigen. The A and B genes, they control specific enzymes which are responsible for the addition of N-acetyl galactosamine in the group A, and D-galactose, it is present in the group B to the H substance. O genes, it doesn't transform H substance, and therefore O is not antigenic because it doesn't transform the H substance H, which is the precursor of all of these alleles. So it is going to be no antigens on the O, while B, it will contain the, what will it contain? It will contain, I just told you now, it is responsible for attaching N-acetyl galactosamine and D-galactose in the A blood group, and that will be, the sugar will be D-galactose in the beta group. So if we talk about the mode of inheritance, then the mode of inheritance is going to be codominant trait. So the A, B and H antigen, they are found on most body cells and also in the saliva and the gastric secretions of most of the individuals. So if you have a person whose blood group is O, they will have OO genotype. That is the point. Group A individuals, they can be simply AA, two A's are present, or A and O, that will be present. So AO means that that person will have a blood group A positive or negative. Similarly, the B group individuals, they can be BB or they can be BO. These are the possible blood groups. So group AD, the persons who have group A and group B, this AB blood group, it means that they have, what does it tell you? That they have both A and B antigens. Just remember by this O. O is, it looks like 0, so 0 antigen on the O blood group genes. But AB, it will have both A and B. So two types of genes, so it can cause more reactions in the body like that. So antibodies to the ABO gene, they will develop in their childhood and their level will start to increase by the age of 10 years. And group O, they have anti-A and anti-B antibodies. So it has no antigen. So that's why you will have A or you will have B. It is going to form antibodies because it doesn't know them, that because it has no genes, so it cannot understand the O blood group. Okay, so it is going to form anti-A and anti-B antibodies. Group AB, so the group AB, it can receive blood from all other types. So who is the universal recipient? AB.
Group.
AB
Oh,
group is the universal recipient because it has no antibodies against anyone. So the universal recipient, people make this mistake very, very commonly. They will say that O is the universal recipient. No, O group is the universal
O is the
donor.
donor. Donor, yeah.
Universal donor, right? And AB is the universal recipient. So then if we talk about the ratio of different types of blood groups in different populations, in the Caucasians, the highest blood group, which is the most common blood group, is going to be O, okay, followed by A. A is found in like 40%, O is found in like 47%, A you can say in 40%, and B group is rare, it is found in 9%, and AB, this combination is 3%. So, these numbers, they seem small, but when you will talk about the full population on this planet Earth, then these numbers, they will become very significant, right? Because 3% of the world population will be like a huge number of millions, like that is the point. So anti-A and anti-B antibodies, these are IgM, and they can cause severe intravascular hemolysis if incompatible blood group has been transfused. That is the point. Okay, so let me tell you about these things. So I will summarize. The group A, so this is the RPC type, group A. So that is the configuration. That will be the shape, that how the antigens are present, like that. And the B, it has this type of antigen, and then you can see that it has 4 group A and group B antigens. You can see that. And this one has no antigens at all. So the group antigens on the surface, these are going to be A. In the group A, the antigen is A. It has antigen A, that's why it is called group A. Group B, it has the B antigens, so group B. The AB, it has both types like we have seen, so this is AB antigens. O has no antigens, so 0, nothing is there. So what type of antibodies they will have in their plasma? This is the antigen. So A antigen is present. So obviously, if you will give the blood group A, they will not develop any antibodies, okay? So they will have antibodies against the group B. Group O has no antibody, no antigen, so there is going to be no antibody. This concept is very simple, right? Blood group A, it will have A antigen. Blood group B, it will have B antigen. Regarding antibodies, so group A, it will have anti-B antibodies, pentamer, like IgM. And group B, it will have something against group B, group A, right? So it will have anti-A antibodies. These are the antibodies. AB, it will have no antibodies at all. Why? Because this group AB is familiar with both A and B because they are part of the AB blood group. Is this concept clear? So it will have no antibodies. That's why it is a universal recipient. Now blood group A people, they don't have any antigen. So if antigen is absent, and then this substance, if we will give it any type of blood, it is going to form antibodies. So it will have anti-A, anti-B bodies. So it is because it doesn't have any type of antigen, so it is going to have both type of antigens. And then important to remember that that blood group O people, they will have IgM and they will have IgG. Other two blood groups, they will have simple IgM antibodies. And here we have both types of antibodies. Then what is the clinical relevance? If a person's blood group is A and he will receive blood group B or even AB, because the B will also contain the B antigens. That is the point, okay? So this person is going to have hemolytic reaction, incompatible blood transfusion. So your patient is going to develop hemolytic anemia. antigens. So the antibodies are already there. So the blood which has been transfused, your antibodies, they will go and fight this system, and then it will result in hemolysis. So blood group A people, they cannot receive type B blood for transfusion. Similarly, if a person's blood group is B, it has and this person has received blood group A or AB, so it has already antibodies against this one. So what will happen? And against the B also, again hemolytic reaction, it will take place. Now think about this person. He has both A and B type antigens, and it has no antibodies, so it will not produce any reaction, and it is the universal recipient of RBCs. Just remember, universal recipient of RBCs. And if you need to give plasma to someone, you can give the AB plasma. AB plasma, because it will not provoke any type of reaction. So this is universal donor of the plasma. Now think about the blood group O. Blood group O, it will receive any blood which is not non-O group. Then what will happen? It has antibodies against group A, group B. So you give them group A, group B, or AB blood, then they're going to show the hemolytic reaction. So they are universal donors of the RBCs, and since they don't have any and then they can receive all types of plasma, because this they will not have anything against them, but the RBCs against them, they have these antibodies, so they are going to produce bleeding there, hemolytic reaction and breakdown of the cells. Now the second system of the blood grouping, this is Rh positive or Rh negative. Then I wanted to tell you that we are familiar with only this type D antibodies, but you should remember that there can be many different types. So at least there are 6 antigens. What are these 6 antigens? Capital C, capital D, capital E, and then small c, D, and E. That is the point. Okay. So an individual who has capital C cannot have small c antigen. These are more specific, so they will have just one type of antigen, right? So if this, like this is the Rh factor, and this is the Rh negative, Rh positive, Rh negative. So you can see here that RBC type, this is the RBC type. So what are we going to see? We are going to see the Rhd antigen. It is present on the positive people. It will have no antibodies. And the Rh negative, they have no antigen on the surface. Negative, they have no surface, okay? But they will have antibody. Rh positive, they have no antibody. But Rh negative, they will have antibodies. So the person who is Rh positive, they can receive either Rh positive or Rh negative blood. While who is positive, they will not show any reaction. So these Rh factors, they are also present on the RBCs like that. So they can receive either Rh positive or Rh negative blood. Now look at the Rh negative blood patients. If the mother is Rh negative, then we will have to give them anti-D immunoglobulin during and after each pregnancy to prevent anti-D immunoglobulin formation, otherwise there will be hemolysis. So the 6 antigens, like I have told you in the Rh system, C, D, E, and then small c, D, and E. So D antigen, this one D, that is the most antigenic. Why? Because it has antigen on the surface. And antibodies, their titer, it will increase slowly and it will reach the peak level within 2 to 4 months after exposure. Transfusion reaction in the individualized, in the persons who are not sensitized, that is a delayed type of hypersensitivity. That is not an acute reaction. Okay. So D antigen, it can cause severe rhesus disease. C and E antigens, they can cause mild fetal hemolysis. Usually the first pregnancy is not affected, but maybe if the mother had received incompatible blood transfusion, then it can be affected. The offsprings of the individual who are Rh negative, like the mother and father are both negative, then their baby is going to be definitely 100% going to be Rh negative. But if the person has like Rh negative and mother or father, anyone is Rh negative and the other one is Rh positive, then what will happen? Like they will be heterozygous. Why they will be heterozygous? Because they are getting one gene from each father. So both negatives, the baby is going to be negative. And if one of the parents is positive, then that person is going to be heterozygous. Heterozygous means that he will have capital D and small d in the system. That will be the Rh negative. So the significance related to this one is the hemolytic disease of the newborn. This is also called erythroblastosis fetalis. So hemolytic disease of the newborn, and then there can be, you should remember, ABO hemolytic disease of the newborn also. It can be due to Rh factor or it can be due to the ABO blood group. So our Rh factor is negative in the mother and the baby is Rh positive. Then what will happen? First pregnancy, the mother is exposed to the fetal burn, often at the time of delivery. So it will cause formation of the antibodies in the mother. But the baby has already taken birth, so these antibodies are not going to affect the first baby. In the next pregnancies, anti-DIG, now this is IgG, so it can cross the placenta. It will go to the fetus and attack his RBCs, so hemolytic disease of the newborn is produced. Just remember, Rh negative mother. Mother is negative, okay? And the baby is positive. Then these changes are taking place. So how it can be, then baby can develop, if this is severe, then baby can die in the utero due to hydrops fetalis, which is that baby will have so much anemia then that the heart will fail and the baby will die in utero. So what is the treatment? You know that we have to give the anti-D this one. We have to give anti-D immunoglobulin to the woman during pregnancy. You can give at 28 weeks and 30 weeks, at 28 weeks and 34 weeks. Or even if they give you the option of giving a single large dose of 1500 international units, even that is correct. Okay, don't feel that that is wrong. So it should be given after birth also. And it will not only clear the maternal plasma from these antibodies, it will also prevent maternal anti-DIG production also. So it is going to switch it. Now think about the other condition, about the ABO blood group. So mother has type O blood group and type A or B, and the baby is type A or B. It can then again there can be hemolytic disease of the newborn. So if the mother has pre-existing maternal anti-A and or anti-B antibodies, then again this can occur. So basically, you know, these antibodies, these are IgG antibodies, they will cross the placenta and they will cause the hemolytic disease of the newborn and the fetus. If there is mild jaundice, then in the neonate, it will be apparent within 24 hours of the birth. So if the baby is showing signs of jaundice in the first 24 hours after birth, you have to think that there is ABO blood group transfusion type reaction, but that is because of passive transfer of antibodies from the mother to the baby. But this is less severe than the rhesus disease. So we should treat the newborn with phototherapy or by the exchange transfusion. So these two processes, again, you can see that the treatment is the same, but this one is less severe. That is the point. So then another question arises that what are the platelets? Because when we were talking about the blood groups, we should know about the WBCs. We have read about them into the pathology. Remember? So the platelets are important part of the blood. They are 2 to 4 microns in diameter. They are produced in the bone marrow and they come from the megakaryocytes. So the platelets, the importance is that they also don't have a nucleus and their concentration, if we talk about the normal number of the platelets, can you tell me that what is the normal number of the platelets in the body? Large number, somewhere between 150,000 to 400,000. That is going to be the normal number of the platelets. That is the point. So the platelets we know that the platelets, they don't have a nucleus. These are the platelets, okay? So they will have a pale center. So their importance is that they are involved in primary hemostasis, and they have small cytoplasmic fragments, and they are derived from the megakaryocyte. Their lifespan is 8 to 10 days, and when they are activated by endothelial injury, what will happen? They will aggregate with their platelets and they will interact with the fibrinogen to form the platelet plug. And they actually contain dense granules, and these granules, they contain adenosine diphosphate and alpha granules. These alpha granules means that they have von Willebrand factor and they have fibrinogen as well as fibronectin. So approximately 1/3 of the platelet pool, it is stored in the spleen. So the platelets, they also produce thromboplastin. That is important thing about them. Okay? And what is the benefit of thromboplastin? It is going to expedite the process of blood coagulation. So what will happen? The platelets, whenever there is an injury, they will come and they will attach to the wall of the endothelial, injured endothelial cells. They will secrete certain substances and then the platelets will go and attach themselves to the endothelial wall. And then they will be, they basically they attach to the damaged endothelial cells. And which part of the endothelium? Collagen. The collagen tissue is exposed, so platelets will go there and they will aggregate and they will form the hemostatic plug. These platelets, they contain actin and myosin. It is important, and they, this actin and myosin, they are important in clot retraction. This is the process by which the clot will shrink and the serum will come out. And this process of clot formation and extraction of the serum, it will occur within like 30 to 60 minutes. So the platelets, they also have important other important factors, like they will produce different clotting factors, and and they also produce certain growth factors. Which growth factors they are producing, the platelets? Platelet derived growth factor, very simple, that it is going to produce platelet growth factors. That is important. So the basic mechanism is very simple. Blood vessel has been injured, so collagen is exposed, so they will go to the endothelial site and then they will attach to the collagen. Why? Because they have specific receptors. What receptors? They have different types of receptors like GPLP, like this receptor, or GP3A receptor. That is also important for their function. So they will, when they will go to the damaged wall, what will happen? They will produce certain vectors. These vectors, they are produced, and among these vectors, they will produce certain granules. These granules, what they will do? First, for the adhesion, we know that von Willebrand factor, that is also a receptor. If a person doesn't have this von Willebrand receptor, or the number is these receptors are low, then your patient is going to have von Willebrand's disease. Fibrinogen receptor, that is also, you have seen, this is the composition. Just remember these two. You should remember these very well. Okay? So what other things they are producing? Fibrinogen coming from the alpha granules, like we can see. Let me show you the slide. Like we said that it has alpha granules, the platelets, and they have dense granules. The alpha granules, they contain clotting factors like fibrinogen, factor 5, and factor 8. They also contain platelet-derived growth factor, and then the vascular endothelial growth factor, and they contain basic fibroblast growth factor, endostatin, and thrombospondin. These are present in the alpha granules. The dense granules, they contain nucleotides. They also produce serotonin, and they produce also phospholipids, and they can have they will have these lysosomes also in them. And then they will be sensitive to the actions of the calcium also. That is the point. So the platelets, they usually have no nucleus, but they are metabolically active and they are able to express membrane receptors and they will release stored substances when they are triggered. How they are triggered? By injury. Their lifespan 9 to 10 days in the normal individual. And there is an increase in the number of the platelets after injury and surgery because this increases the tendency of the blood to clot. And when in contact with the collagen, the platelets, they will develop pseudopodia or the foot, and thereby they will attach themselves to the collagen and to one another. And platelets, they are capable of producing nitric oxide, prostaglandin, and thromboxane, and but they cannot produce prostacyclin. From where do we get the prostacyclin? You know, when arachidonic acid into the cell membrane is metabolized, then it will give rise to the thromboxane and prostacyclin if we are following the cyclooxygenase pathway. So then the normal platelet count varies between 200,000 to 400,000, and the platelets, they have a role in clotting and they are responsible for formation of intrinsic prothrombin activated, which is responsible for the onset of blood clotting. And they also help in clot deflection and hemostasis or prevention of the blood loss immediately following injury by causing constriction of the blood vessels and sealing the site of injury by forming a temporary platelet plug. That's why, these are very important part of the cells. So without them, the patient is going to have the coagulation disorder. Now the third type of cells which we have in the human body, these are the white blood cells. White blood cells, they can be divided into different types, like the granulocytes, which are neutrophils, eosinophils, basophils, and the mast cells, and the mononuclear cells, like the monocytes and the lymphocytes. WBCs, like we can do the TLC, the total leukocyte count, which is going to tell us about the actual number of the WBCs, and the differential leukocyte count, which is going to tell us about the differential count that which type of cells are present. Neutrophils, 60% of the cell WBCs, then lymphocytes, they make up 30% of the WBCs, monocytes are the 6%, eosinophils are 3%, and basophils are less, 1% or less. Neutrophils, that these are the responsible in the for the acute inflammatory response, and their number rises in the bacterial infection. They have phagocytic actions and they have multi-lobed nucleus, as you can see here. This is a multi-lobed nucleus. The nucleus is going to show you multiple lobes. That's why we call it multi-lobed nucleus or segmented nucleus. Okay, that is the point. So usually they will have like six. If they tell you that this is hypersegmented, then it means that it will have more than 6 lobes. So they have phagocytic actions. They have multi-lobe nucleus, specific granules. They will contain the leukocyte, alkaline phosphatase, collagenase, lysozyme, lactoferrin, azurophilic granules, or the lysosomes, which will contain proteinases, acid phosphate, myeloperoxidase, and beta-glucuronidase. Hypersegmented, they are seen in vitamin B12 or folate deficiency. Increased band cells or means that the immature neutrophils, they have been released into the circulation. So they can show that there is increased myeloid proliferation, like it will occur in cases of bacterial infections and also in chronic myeloid leukemia. So if we talk about the important neutrophilic chemotaxis factors agents, these are complement 5A, interleukin 8, leukotrienes B4, kallikrein, and platelet activating factors. These things should be on your fingertips because they will give you easy marks. Monocytes are found in the blood and they differentiate into the macrophages. Once they are into the circulation, we will call them monocytes. Once they have entered some tissue, then they will become macrophages. So that they will have like large kidney-shaped nucleus and they have like a frosted appearance, like they have been frozen somewhere. Okay, so they will not be like very clear. Macrophages, we have just read about them, that if the RBCs, that if the these macrophages and monocytes, they go into the tissue and they will form the macrophages. Macrophages, they are going to eat bacteria, or we can say that they are going to phagocytose the bacteria, cellular debris, and the RBCs, which are very old. They have these monocyte macrophages, they have long life in the tissues, and they are differentiated from the circulating blood monocytes. These macrophages are activated by gamma interferon, and they can function as antigen presenting cells via the major histocompatibility complex 2. You know that T cells, they need that we should present the antigen to them in a process form, only then they will develop some reaction against them. Macro means that they are very large, and phage means that they are eaters. So they are the large cells which are the eater of the different other cells. Their name can be different according to the site where they are present. Like you will call them Kupffer cells when they are present in the liver. You will call them histiocytes when they are present in the connective tissue. When they are present in the skin, we call them Langerhans cells. You have seen that in the epithelial, that in the allergic reactions, you are going to see the Langerhans, even in the Langerhans cells, if there is some skin tissue and the reaction is there. We call them microglia when they are present in the brain. And osteoclasts in the bone. The osteoclasts in the bone, what are they going to do? They are the bone eater cells. Like, the osteoclastic and the osteoblastic activity is going side by side into the bone marrow. When these cells are present into the brain, then we call them microglia, but they have phagocytic actions. They are important, macrophages are important component of the granuloma formation, like in cases of TB and the sarcoidosis. Lipid A from the bacterial lipopolysaccharide, it will bind CD14, which is present on the surface of the macrophages, and it will initiate the septic shock. So then I have a question for you, that if you have a patient with a wound granulation formation, so what type of cells you are going to see? Giant cells, right? That will be a giant cell granuloma, and you are going to see the macrophages, which will be like pressed, and they will look like the epithelioid cells. Eosinophils, these are the pinkish appearing cells, so maybe the only WBCs which are appearing pinkish into the appearance on staining. So these eosinophils, they defend against helminthic infections like because they have major basic protein. So if there is worm infestation, then your patient will have high eosinophilic count. So they have bilobe nucleus, and they are packed with large eosinophilic granules of the uniform size. That is the point, okay? The cells are going to be of the same type. They are highly phagocytic for antigen antibody complexes, and they will produce histaminase, major basic protein, and this is also called a helminthotoxin against them, and eosinophil peroxidase. Eosinophil cationic proteins and the eosinophil derived neurotoxins are present. So basically, we say that these cells, they like pink color. Philic means that they have a tendency, they like something. That is the point. So if they ask you that the eosinophil count has increased tremendously, so what is the cause? So here are the causes. Parasites are there, asthma is there, Shrug-Strauss syndrome is there. This is an abnormality where the person is going to have, arteriovenous malformations, plenty of capillaries into the nose, sinuses, and then the lungs and the kidneys infections, they are likely to occur. That is Shrug-Strauss syndrome. Then in chronic adrenal insufficiency, like the supraadrenal gland is not working well. Then in myeloproliferative disorders, like like the chronic myeloid leukemia, other type of tumors of the bone marrow. Then in the allergic processes, and then also in the neoplasia. These conditions should be on your fingertips. Also in the allergic processes, you are going to see a lot of eosinophils. In cases of neoplasia, like the Hodgkin lymphoma, you are going to see many eosinophils. Now the remaining cells, basophils, because they will take up a blue dye. So they will mediate allergic reaction. as you know, that densely basophilic granules, and they contain heparin. Heparin is an anticoagulant and also contain histamine. Histamine is a vasodilator. Leukotrienes, which are synthesized and released on demand. Leukotrienes also, they are coming from the, there is phospholipid membrane which contain in each cell, which contain arachidonic acid. This arachidonic acid is changed to the cholesterol, and then cholesterol can follow one of the pathways. It can go along the lipo-oxygenase pathway or cyclooxygenase. When it enters, the cholesterol enters the cyclooxygenase pathway, you will get prostaglandin. If this enters the lipo-oxygenase pathway, then you are going to get the leukotrienes. Leukotrienes, they are going to cause vasoconstriction and they will induce like asthma. So that's why we give them leukotriene inhibitors if someone is asthma. They are basophilic. They will readily stain blue with the basic stains. Basophilia is actually uncommon, but it can be a sign of myeloproliferative disease, particularly chronic myeloid leukemia. Okay, then the mast cells. Mast cells, these are bluish. They mediate allergic reaction in the local tissue. They contain basophilic granules and they originate from the same precursor as the basophils, but they are not the same cell type. So mast cells and the basophils, they are two different type of cells, but the parent cell is going to be the same. They can bind the Fc portion of the IgE to the membrane, and then IgE is the antibody, so Fc portion it will bind to the membrane. These cells, they are activated by tissue trauma like C complement 3A and 5A surface IgE, and then cross linkage will occur by antigen IgE receptor aggregations, they will occur, and all of these, and this series of events, it will lead to degranulation and release of the histamine, heparin, tryptase, and eosinophilic chemotaxis factors. So mast cells, they are basically involved in type 1 hypersensitivity reaction. Then chromoline sodium, it will prevent mast cell degranulation. That's why it is used for the prevention of prophylaxis of the asthma. But chromoline sodium, it can be in the form of tabs or can be in the form of inhalers like that. If someone is found to have the allergic reactions, then you will have to measure the level of the tryptase. The tryptase, when they can ask you about the tryptase, like a mother has developed severe anaphylactic reaction to some drug or something. So how you will know that she has developed anaphylaxis? So you will have to assess the level of the mast cell tryptase. You will do at the same time, and then you will repeat at the time of reporting of this collapse in the mother, and then you will repeat that after 24 hours. Then in the blood, you can see dendritic cells. These are highly phagocytic antigen presenting cells, these dendritic cells, and they function as link between the innate and the adaptive immune systems. Dendritic cells, they express major histocompatibility class 2 and the Fc receptors on the surface, and these are called Langerhans cells in the skin. So actually the Langerhans cells in the skin, these are dendritic cells. Lymphocytes, you have read about them a lot when we were doing the immunology. So they refer to the B cells and the T cells, and third type of lymphocytes are natural killer cells. B cells and the T cells, they mediate adaptive immunity, and the natural killer cells, they are part of the innate immune response. These are, as you can see here, these are rounded cells, and they have like deeply staining nucleus, and with small amount of a pale cytoplasm. Cytoplasm is very less and scanty. You can see in the center it is pale. These cells are part of the humoral immune response, and they originate from the stem cells in the bone marrow, and they will mature in the marrow. So they migrate to the peripheral lymphoid tissue, like the follicles of the lymph nodes or the pulp of the spleen, and they can also go to the unencapsulated lymphoid tissue, like in the gut. They can go and they can mature there also. So when an antigen is present in the body, the B cells, they will differentiate into the plasma cells, and the plasma cells, they are going to produce antibodies. So B cells, they are not going to produce antibodies directly. They will change into plasma cells, and then they will produce antibodies. And then they will also form memory bodies. And remember that the B cells, they can also act as the antigen presenting cells. So if we look at the B cells, they have certain surface receptors. They will have CD19, CD20, and CD21 on their surface. That is one type. Okay. Now look at the T cells. T cells, as you know, that there are two different types: cytotoxic cells, which will have CD3 and the CD8 receptors on the antigens on the surface. And at T helper cells, they will have CD3 and CD4 on the surface. These things are very basic and you should remember them. T cells, they mediate cellular immune response, and these cells, they originate from the stem cells in the bone marrow. You know, both cells are originating from the bone marrow, but they are maturing in different places. And they will mature into the thymus, and they will differentiate into cytotoxic T cells, which will express CD8, and they will recognize CD8 cells. They will recognize major histocompatibility complex 1. Helper T cells, they express CD4 on their surface, and they are going to recognize major histocompatibility 2 complex. And then we have regulatory T cells. So CD28, these are the core stimulatory cells which are necessary for the activation of the T cell. So CD28, we require that cell for activation of the T cells. Most circulating lymphocytes, they are the T cells, 80%, and they are coming from the thymus. And CD4 helper cells, they are primary target of the HIV. Just to remember it easily for the exam sake, you can say that the rule of 8 is major histocompatibility complex into CD4. The product is going to be 8. 2 into 4 is equal to 8. Then major histocompatibility complex 1 plus the CD4 or CD8, then the production is again 8. This is just to facilitate you, otherwise no significance. Plasma cells, they produce large amount of antibodies which are specific to a particular antigen. So they can be like, you can say that whenever they are exposed to some type of antigen, then they are going to produce certain changes, like there will be, what will happen, the chromatin, it is scattered throughout the cell. That's why we call that clock paste. Cell, they have eccentric nuclei, they have plenty of rough endoplasmic reticulum, and they have well developed Golgi apparatus also. And then they are found in the bone marrow and normally, and they do not circulate into the peripheral blood. So the platelets, we have just read about them. So now that what is the function of why these cells are important in the importance of the coagulation of platelets, why they are basically important? What do you think? Because we have just said that they are like important in maintaining the coagulations in the body. So coagulation, where does it happen? So coagulation system, there are two pathways, like the extrinsic pathway and the intrinsic pathway. So the intrinsic pathway, this is initiated. This is the intrinsic pathway. This is initiated by exposure of the blood to the negatively charged surfaces such as the collagen in the living person, or the glass when there is in the test tube. So in vitro, when they will come in contact with the glass, then this intrinsic system, it will be activated. Or when the collagen is exposed, collagen, you know, protein, so this is a negatively charged surface, then the intrinsic system of the coagulation, it will be activated. On the other hand, the extrinsic pathway, how it will be activated? Extrinsic system, it will be activated when tissue thromboplastin is released after tissue damage. So basically, you should remember the commonality that both systems, they are activated in response to injury, because that is the conservative mechanism of the body, that how it should protect itself from the effect of different harmful substances and the injectory in response to injury. So both pathways, they are activated by, they will start by activation of different particles, different blood clotting factors. So the intrinsic pathway, it will be activated by conversion of factor 7 to 7A, we call it activated factor. It will act on factor 9, the factor 11, and it will be converted to activated factor 9. Then the factor, this is 11, activated because it is going to stimulate it, so it will become factor 11, 11A. This complex, what will happen? It will also activate as cofactor. It will stimulate conversion of factor 9 to factor 9A. That is the point. Okay? So here we need factor 8 as a cofactor. Cofactor is something which is going to facilitate action of a factor. So factor and cofactor. Now look at the extrinsic pathway. It will start with conversion of 7 to 7A, and that tissue factors, they are going to act here. And then we said that tissue thromboplastin, that is going to initiate this process, while collagen basement membrane, or what was the second thing, that the collagen membrane, it has been injured, so the body is starting to react in response to this one. Then these two, intrinsic and the extrinsic, they are going to merge at this point. So factor 10, it will be converted to activated factor 10. And then what will happen at this point? In the presence of cofactor, which is factor 5, which is converted to 5A, prothrombin, it will be converted to activated thrombin. And then this activated thrombin, what it will do? It will act here, and the fibrinogen, it will form the fibrinogen fibrin monomers. So basically this step means that, you know, the fibrinogen, just remember, fibrinogen is soluble. But by the action of thrombin, it will become insoluble. It will not be dissolvable, so this will be a clot. So what will happen here? The cofactor can be activated factor 13. That is the point. Okay? So apart from the first two steps of the intrinsic pathway, only these two steps, rest of the steps are going to be the same in both pathways. You have seen that they will combine, and then rest of the things, they will continue. Citrate and so you should remember that calcium is required in this process as a cofactor, because if there is no calcium, then blood will not coagulate. Blood will not form the clot. If there is blood will not clot in the absence of calcium. So all steps of the coagulation cascade, they depend upon the presence of calcium. And blood will not clot if there is no calcium. Remember, it's simply like that. If no calcium in the system, the blood will not clot. That's why when we are storing blood, we are adding calcium to the blood. Why? Because we want to keep it anticoagulating. Citrate and oxalate, they can remove the calcium and they can prevent clotting. So aspirin, it will prevent platelet aggregation only. Aspirin is going to prevent the aggregation of the platelets only, but it will not, but once the clot is formed, but it will have no effect. But because it will not prevent formation of the clot, only adhesion of platelet. If you remember, aspirin is just antiplatelet. These things are important when we will go to the pharmacology. Now, the bradykinin. Bradykinin, this is high molecular weight kinin. It, by the presence of kallikrein, it will change into bradykinin. Bradykinin, it is, so all of this is also activated. This kinin cascade is also activated whenever there is injury. So then when this bradykinin is present, it has three functions in the body. It will increase vasodilation. It will increase permeability, so the more tissue fluid will come out, and it will produce pain. So all of these are features of what? They are features of the acute phase inflammatory reaction. This high molecular weight kallikrein, this is also required for conversion of factor 12 to 12A. So if you remember, in the intrinsic pathway, it is starting with factor 12. And the extrinsic pathway, it is starting with activation of factor 7. So since we are talking about the clotting, so it will be good and beneficial if we talk about the anticoagulants also. Factor 10A, when it is focused, so which substances are responsible for this action, as like anticoagulants? Low molecular weight heparin, then heparin, and these are direct factor activated 10A inhibitors. They have, if you will appreciate, they have no action on the factor 10, but the activated factor 10A, which is 10A as activated factor, so it will be inhibited by these anticoagulants. What are these drugs? Low molecular weight heparin, and direct, and then there are direct factor X, factor 10 inhibitors like apixaban, rivaroxaban, and fondaparinux. These are the direct inhibitors, and then the fondaparinux is another type of blood thinner. So if the patient has tendency to form the blood clots, like we have read about the VTE, then we need to give them anticoagulants. So they are basically targeting factor, activated factor 10. Another type of anticoagulants, they are going to focus target thrombin. And we know, again, you should remember that some are focusing on activated factor 10 and some are focusing on activated factor 2. So here we include heparin, which is it has the greatest efficacy. Then the low molecular weight heparin like the deltaparin and the enoxaparin. Then direct thrombin inhibitors like ergotaban and dabigatran. Okay, these are the direct one and the others are indirect one. So these are going to prevent the clot formation. Just remember, they are going to inhibit clot formation. But now if your patient has developed a clot, then what you will give? We have just read that for the conversion of the clot to a stable clot, we need prothrombin and thrombin. And then in the presence of this plasminogen, these clots are formed. So what we need, if we will have plasmin in the system, it is going to dissolve the clot. So thrombolytics like reticulase, alteplase, streptokinase, and tenecteplase, they are going to promote the action of tissue plasminogen activator, and then plasmin will be there, and what will happen? This mesh is there, so fibrin degradation products are formed. This is the fibrinolytic system. This system is inhibited by aminocaproic acid. It will inhibit conversion of tissue plasminogen activator. So this process of clot dissolution, it will be abolished. That is the point. So here this is the key, that where we have this purplish violaceous point. This is inhibited by a vitamin K antagonist, which is warfarin. So warfarin is going to have action on multiple levels. If you will look at this one, 2, 7, 9, and 10. These are vitamin K dependent blood clotting factors, so they are inhibited by warfarin. The green ones, these are the cofactors. Factor 10, factor 8, and factor 5, these are the cofactors. That is the point. Okay, so we need them if we want to have the proper coagulation into the system. So coagulation cascade, if we will roughly describe it, what happens here is that there is a stage of coagulation followed by the coagulation. So oxidized vitamin K, and here the warfarin is going to stop this enzyme epoxide reductase. So there will be reduced vitamin K, and then what will happen? We will get, in the presence of certain cofactors, we are going to get inactivation of the factor 2, 7, 9, 10, and from protein C and protein S. They all will be inhibited. So what will happen in the presence of the alpha glutamyl carboxylase? They will change into mature or the active 2, 7, 9, 10, C, and S. And we need this enzyme for converting the inactive factor 2, 7, 9, 10, C, and S to this one, to the active factors. You should remember that the clotting factors which are present in the plasma, they are present in the inactive form. And then by the action of certain enzymes like the vitamin K dependent enzymes, what will happen? They will change into the mature or active blood clotting factors. So if a patient has high tendency to form the blood clots, then we are going to stop this action, like oxidized vitamin K will be there, but it will not be changing into the reduced form. So no reduced form, so we cannot have alpha glutamyl carboxylase, so we will have inactive factors. This active conversion will not take place. That is the action of the warfarin. But remember, aspirin is this warfarin is not directly inhibiting alpha glutamyl carboxylase, it is inhibiting oxide reductase. So regarding vitamin K deficiency, vitamin K deficiency, it can occur in certain conditions. We will talk about them. What will be the effect of vitamin K deficiency? So the vitamin K dependent factors are 2, 7, 9, and 10. So if we don't have any vitamin K in the system, there will be decreased synthesis of factor 2, 7, 9, 10, protein C, and protein S. Warfarin is going to inhibit vitamin K epoxide reductase, and vitamin K administration, it can potentially reverse inhibitory effect of warfarin on protein factor synthesis. Fresh frozen plasma or plasma and cofactors administration, it will reverse actions of the warfarin immediately, and it can be given with vitamin K in cases of severe bleeding. It can be given. Okay? And neonates, they lack enteric bacteria because their gut is sterile. And what will happen? So these bacteria which are present in the gut of a person, they will produce vitamin K. So the neonates, they don't have any enteric bacteria, so the vitamin K is not produced. So that's why once the baby is born, we will have to give them vitamin K. So as a routine process, when the babies are born, we have to give them 1 milligram of potassium as intramuscular injection given mostly into the thigh or the buttock of the baby. So it will overcome the neonatal deficiency and prevent coagulopathy. Important example will be as they do in cases of obstetric cholestasis, because or if you are suspecting this ITP in the baby because mother has history, then you will have to give them vitamin K. Remember a few things about the factor 8 and factor 2. Factor 2, it has the shortest half-life, and factor 2, it has the longest half-life. And von Willebrand factor, it carries or protects factor 8. So if there is deficiency of factor 8, von Willebrand factor, your patient is going to have bleeding disorder. That is the point. Okay. And similarly, there can be in thalassemia and not thalassemia. When you are going to have deficiency of vitamin of this factor 8, very common condition, hemophilia. These things should be on your fingertips right now. So there are certain, and like I've told you about the drugs which are anticoagulants like the heparins and other stuff. And then we have natural anticoagulants in the body. These natural anticoagulants are antithrombin 3, protein C, protein S, and heparin. You know, heparin is also produced by the platelets. And then the smoothness of the endothelial surface is important in preventing intravascular coagulation, because if the endothelial surface is irregular, then again clotting will take place. Tissue thromboplastin, it will activate the extrinsic pathway, and the plasmin, it will cause clot lysis, but it will not prevent clot formation. So you have seen here also, like I will go back to the picture, that plasmin, this is a clot buster. Okay, so but it has no action, it cannot prevent formation of the clot. So when you are giving these enzymes, why we don't give these enzymes? Because they are not going to keep the blood liquid. We have to give the anticoagulants, and these are thrombolytics, like they are going to break down a clot. That is the importance. Okay, so both are different things, so they are clot busters. So that's why this plasmin, it cannot prevent formation of the clot, so that's why it is not given as a blood thinner. That is the point. Because plasmin, it will not prevent formation of the clot, it is just going to bust the clot which has developed into the circulation. So these are the important points. And then about the lysis of the clot, that how it will take place or how anticoagulation will take place. So what happens is that plasmin is formed from the plasminogen by the action of the thrombin, activated factor 12, and the lysosomal enzymes. Plasmin is a proteolytic enzyme, so it is going to digest. Plasmin is going to digest the fibrin. So there will be fibrinolysis. That is the point. So if is the plasmin, it is also going to digest factor, it will digest this fibrinogen, and then it will also ingest or eat factor 5, 8, and 12. So that is the action. Okay? So anticoagulation activity in the body, how it will continue. We have like protein C. So what will happen, like if there is thrombin or thrombomodulin complex, and it is why it is present, because there was some endothelial injury, and this protein C, it was activated, and why this clot formation, and then it caused release in the presence of protein S. It caused cleavage, broke down factor 5A and 8A. So that's why the clot didn't form. This is the action of activated protein C. Now the plasminogen, it is present. So what will happen in the presence of tissue plasminogen activator? It will form plasmin, and plasmin is an eater of the blood clot. So it will cause fibrinolysis. So it will do what it will do. It will cause cleavage of the fibrin mesh, and then it will cause destruction of the coagulation factor. And this is the normal anticoagulation in the human body. So antithrombin, it is going to inhibit activated forms of factor 2, 7, 9, 10, 11, and 12. Heparin is going to enhance the activity of antithrombin. So the principal target of antithrombin are the thrombin and the factor 10. So factor 5 leading mutations, they will produce a factor 5 which is resistant to the inhibition by the activated protein C, and tissue plasminogen activator. It will be used clinically as a thrombolytic. So if we talk about the functions of the platelets, function of the platelet is to keep the hemostasis into the body. That whenever there is injury, this platelet should go and it should take action. So let's say that first step was that there was endothelial damage. So first reaction is going to occur, that is vasoconstriction. Why? Because of the neural stimulation reflex and endothelin, which is released from the damaged cells. So there was exposure of the endothelial surface. So what happened? This is the exposed surface. Von Willebrand factor, it will bind to the exposed collagen. So the von Willebrand factor, it is coming from the Weber plate bodies of the endothelial cells, and also coming from the alpha granule cells of the platelets. First step was injury, then exposure of the collagen. Now adhesion will take place. So platelets, they are going to bind the von Willebrand factor via the GP1B receptors, and which are present on the site of GPLB receptors, which are present on the site of injury only, and these are specific. It will cause activation of the platelets. The platelets, they will undergo changes in their appearance, in their conformational changes, and what will happen? The platelets, they are going to release ADP and calcium, which are necessary for the coagulation cascade, because in the absence of calcium, nothing will take place. And then the platelets, they are also going to release thromboxane. So ADP, adenosine diphosphate, it will help platelets attach to the endothelium. So by release of ADP in the presence of calcium, there is activation. So what will happen? Platelets are active now. So ADP is going to bind to the P2 by 12 receptors, and they will induce this platelet receptors expression at platelet surface. These receptors are the GPLB and the 3A, GP2B and the 3A. These receptors are exposed on the surface of the platelet. Then what will happen now? Aggregation of the platelets, it will take place. So fibrinogen, it will bind glycopeptide 2B and the 3A receptor, and it will link platelets. So platelets, they will come and they will form, they will aggregate. So there is aggregation. So more ADP is released. So more adhesion will take place. So actually in the platelets, two types of activities are going on: pro-aggregation factors and there are anti-aggregation factors. So the pro-aggregation which are going to promote the formation of the clot, and those who are going to inhibit the formation of the aggregation of the platelets or the clot. Thromboxane is released by the platelets. It will cause vasoconstriction, we have read, and then it will cause increase in the platelet aggregation. So they are going to promote aggregation. On the other hand, anti-aggregation factors like prostacyclin and the nitric oxide, they are vasodilator. Okay? They are also released by the endothelial cells. These are vasodilators, so the blood flow is going to increase, and blood flow is increasing, then the platelets, they will be washed away from there. Okay, so it will lead to decreased adhesion of the or aggregation of the platelets. So by these actions and the balance between these actions, temporary plug, it will stop bleeding, and this will be unstable and it will be easily dislodged. So what will happen? This primary clot has been formed. Now the secondary coagulation cascade and hemostasis will take place, and there will be activation of the coagulation cascade. That's how the more stable clot will form, and it will inhibit any ongoing bleeding into the system. So in a normal person, this section is going to be continued like that. You can ask me that what type of substance is plasminogen. So plasminogen, this is a single chain beta globulin molecule. This is a plasminogen, is also a glycoprotein, and it is synthesized by the liver, and it is plasminogen is present in the body fluids including saliva, tears, seminal fluid, and the prostatic gland secretion also. Half-life is roughly like 2 days, and that is all about the plasminogen that you need to remember. That is the point. So if we talk about the zymogen, it will have no enzymatic activity until it is converted to plasmin by the plasminogen activator. Then tissue plasminogen activator, it is, as we know, it is produced by the endothelial cells and the smooth muscle cells and the neurons, megakaryocytes, monocytes, and fibroblasts. Serum protease inhibitors, they include alpha-1 antitrypsin and alpha-2 macroglobulin. And these are going to limit the actions of the plasminogen activation. If we talk about the streptococci, then you know they also release streptokinase. So streptokinase, it will convert plasminogen to plasmin, and then plasminogen, it is going to inhibit the fibrinolysis. It is going to digest the fibrin clot. So now if I asked you about the vitamin K dependent clotting factors, so you will tell me that 2, 7, 9, 10, they are dependent upon vitamin K. These things, you know, should be on your fingertips because they are going to ask you questions. So vitamin, and the factor 2 is prothrombin. Then regarding this clotting time and the bleeding time, let's go to that. Thrombogenesis, this means the process of formation of the blood clot here when the coagulation cascade has been activated. So it means that formation of thrombogenesis, it means formation of insoluble fibrin mesh. Aspirin is going to irreversibly inhibit cyclooxygenase enzyme, thereby it will inhibit thromboxane A2 synthesis. So if there is no thromboxane A2 activity, there will be no aggregation of the platelets. So that's why aspirin is antiplatelet factor. And if you have to do surgery, at least 5 days before surgery, you should stop giving aspirin so that your patient will not have plenty of oozing from the surface at the site of the injury. Drugs like clopidogrel and parasugrel and
Before,
yeah,
doctor, before how much stop aspirin? Because there is risk about this.
5 days. 5 days before the operation, you should stop. And you know, if your patient is stable, she has no additional risk factor, you are planning a cesarean section, then you can stop at 36 weeks also. But if your patient is coming in emergency and you need to do the cesarean section, then of course you cannot wait for 5 days. Then you will have to do the surgery, and what you can do is that you will keep a subrectus drain. So that is the point. So, but if you are doing the elective surgery, then you can always stop it. That is the point. Okay. So, anything else? Any other question?
No, thanks.
Oh. Other antiplatelet agents are clopidogrel, perasogrel, and the ticlopidine. They inhibit ADP-induced expression of the glycoprotein 2B and 3A receptor. By irreversibly, they will block the P2Y12 receptor. And these other drugs like efiximab, epitifibatide, and the tirofiban, they will inhibit this receptor. You know, this receptor is present on the surface of the platelets. So these drugs are direct inhibitors of this receptor. Then listocetin, it will activate von Willebrand factor to bind to G glycoprotein 1B receptor, and failure of aggregation with this listocetin assay, it will occur in the von Willebrand disease and in the Bernard-Solier syndrome. In von Willebrand disease, we don't have the von Willebrand factor, and here the Bernard-Solier syndrome, it means that the platelets, they are unable to move actively. So if they cannot move, then they cannot lead to formation of the clot. That is the point. Okay? So you know that these drugs, they are going to, like some of the drugs, they are going to inhibit this coagulation cascade directly. And some, like this ristocetin, it will activate the von Willebrand factor to bind glycoprotein 1B receptor, and failure of aggregation with this with addition of ristocetin, it may say it means that there is von Willebrand disease. Because you know, for this activity, for binding to this substance, there should be some you know, this von Willebrand factor. But if it is not present, then it means that patient has von Willebrand disease or it has Bernard-Solier syndrome. That's why the you know, these platelets, they are not functioning properly. The platelet, inside the platelet, we have von Willebrand factor and we have fibrinogen. Arachidonic acid, you know, it is coming from the membrane cholesterol, and when it will, by the action of the cyclooxygenase enzyme, it is going along the cyclooxygenase pathway and it is forming thromboxane. Thromboxane, we know it is going to promote clot formation. So if we will give aspirin, it is going to inhibit this conversion of this arachidonic acid to this one thromboxane. So no thromboxane is formed, so the patient is going to have thin blood. But once the clot is formed, then aspirin has no action. Now look at the other points, that clopidogrel, ticlopidine, perasogrel, they are going to have a negative effect, like they will decrease the expression of this ADP receptor on the surface. And then what will happen? They will inhibit this induction of the insertion of this glycoprotein 2B3A receptor. So when this receptor is not expressed on the surface, you know that this receptor is not there. This Y receptor is already there, but this one is required for activation. Activation of the Y receptor to this active form. So if there is deficiency, this action is stopped, then they cannot express it on the surface. This means that this is P2 by 12 receptor. So they will be inactivated by these drugs. If there is deficiency of this receptor, like in cases of Glanzmann thromboasthenia, see even the name thromboasthenia, where the movement of the platelet is very slow. Weakness, very slow, like aged person. So what will happen? It will not move. So there will be less amount of these receptors on the surface. So what will happen? This clotting factor, this coagulation, they cannot participate in the clot formation. So if this one has been stopped, it will lead to less formation of the fibrinogen. That is the point. Okay. So if we have to inhibit this receptor, we will have to give tirofiban, epitifibatide, and efiximab, like just now we said. they are going to inhibit the activity of this receptor directly. So the patient will not develop blood clot. That is the point. Because you can stop this process at many different points like that. So that if there is deficiency, like in the Bernard-Soulier syndrome, what will happen? There was damage to the endothelial surface, collagen was exposed, and this receptor was, they went and they had some effect on the receptor, and then what happened? Ideally, here the clot will form. But if there is deficiency of the von Willebrand factors disease, then the platelets, they will not attach here, and if they will not attach here, then the vascular endothelial damage, it will not be repaired like these changes will take place. So if these are the vascular endothelial cells, then we know inside the cell what will happen. This one is the purple one is the von Willebrand factor. So this von Willebrand factor is expressed because it is going to act as a glue, and then the platelets, they will come and attach. So if there is receptor for the GP1B, so if there is deficiency of this receptor, then you can understand that if this receptor is not here, then how the platelet will come here and attach itself here. So it cannot. Okay, that is the point. So if there is like a von Willebrand factor and factor 8 are present, thromboplastin is present, and tissue plasminogen is there, and the prostacyclin is here, then all of them are going to inhibit. We read about that they will inhibit aggregation of the platelets. So the bleeding will continue like that. Or if the patient has tendency to form clots, then we are giving them these substances, then these tests will not take place like that. Okay, so the coagulation studies. Why we do the coagulation studies? Because we want to see that patient is developing the blood clots or not developing blood clots, and this has the normal bleeding and the clotting times or not. The bleeding time, this is the time interval beginning from oozing of the blood after a cut injury till arrest of the bleeding. Bleeding time, it is determined by the platelets and by the vascular contraction. Normal duration of bleeding time, it varies between 3 minutes and 6 minutes, and it will be prolonged in cases of purpura. And the platelet count, which is below 20 to 40,000 per liter, then it will cause serious bleeding because the bleeding time will decrease a lot. So purpura also the bleeding will take place due to deficiency of the platelets like that. The purpuras are the bleeding points like that. Second important definition for you, clotting time. So clotting time, this is the time interval from oozing of blood after a cut or injury till the formation of a clot. So that is the before the formation of the clot, then we will see that this is the clotting time. Its normal duration varies between 3 and 8 minutes, and it is prolonged in cases of hemophilia because we don't have blood clotting factor 8. What is prothrombin time? The prothrombin time, it measures the clotting time from the activation of factor 8 to the formation of the fibrin clot. It is the time taken by the blood to clot after addition of tissue thromboplastin to it. This is a lab test. Okay, so this test measures the integrity of the extrinsic and the common pathway of coagulation. So since the prothrombin time, it assesses the extrinsic pathway, so it will be prolonged in cases of abnormalities of factor 8, 10, 5 or factor 2. So the PT, it is going to measure the activity of these factors. That is the point. Okay, factor 8, 10, 5 or 2. That is the point. Okay. So the normal thromboplastin time, this is 16 to 18 seconds. In some situations, the PT or the prothrombin time, it will be prolonged. Like in cases of warfarin therapy, or the patient is getting unfractionated heparin, and it is not like the lower molecular weight heparin. This is heparin, unfractionated one. Then in DIC, and then in cases of liver disease, like in cases of cirrhosis of liver. The coumarin or the warfarin, it will interfere with the vitamin K metabolism. It will inhibit the gamma carboxylation of factor 2, 7, 9, and 10, and it will also prolong the prothrombin time. Vitamin K, if it is given, it will restore the normal prothrombin time, and then it is used therapeutically if the this prothrombin time is prolonged. or the INR is very high, then you will have to give vitamin K to your patients. This is very important for the safety of the patient and to maintain life-saving event like that. Now, what is activated partial thromboplastin time? Activated partial thromboplastin time, this is the time taken for the blood to clot following the addition of an activator such as phospholipid along with calcium to it. So it is also called activated partial thromboplastin time. Therefore, the activated partial thromboplastin time, it will measure the integrity of the intrinsic system and the common pathway of coagulation. Normal duration of the partial thromboplastin time is 30 to 45 seconds. Apart from detecting the abnormalities in the blood clotting, measurement of the APTT, this is also used for monitoring the treatment effects with heparin, which is a commonly used anticoagulant during pregnancy. Activated partial thromboplastin time, this is prolonged in cases of heparin or warfarin therapy, as well as if there is deficiency or inhibition of factor 2, 7, 8, 9, 10, 11, and 12. That is important information that you should remember. So you can understand that coagulation system is very important. You should know about all of these things. Then you should also know about the formation of the clot and then how you are going to prevent clot formation. Both mechanisms you can understand only if you have good background knowledge. Okay, if you don't have good background knowledge, then you are going to have problem in the exam. So another very important topic in the related to the hematology, that is blood transfusion. Blood transfusion, it means that something has happened into the body. There is deficiency of clotting factors, and then or the patient is hemorrhaging and you need to give them blood. This is called blood transfusion. So it can be of two types, emergency or the planned. Emergency, where we didn't anticipate and something has happened, like the postpartum hemorrhage, or the patient has like a placenta previa and then the hemorrhage has taken place. So we will have to offer emergency transfusion. Then the planned transfusion. Planned transfusion you will offer if your patient is having hemoglobinopathies like sickle cell disease and thalassemia. So in both of these conditions, you will never give iron because the system of the patient is already overloaded. So if you will give them iron, it is going to worsen their condition. So that's why you have to give them direct blood transfusion. So then the question, then you should know that what are the indications for transfusion. So basically, what type of blood components we can offer for transfusion. So blood components such as RBCs, platelets, fresh frozen plasma, cryoprecipitate, they are obtained from the single donation of the blood. So we can always, like you have one big part, this collection of blood, then you are going to sort it out and you can get different type of components. So all blood used for the transfusion, it should be negative for HIV, hepatitis B, C, and syphilis. Even CMV negative, that is, if your patient is pregnant, you will need CMV negative, cytomegalovirus negative blood also, because that can cause pathology in the baby. Clotting factors, albumin, and immunoglobulins, they are prepared by using plasma from many donors. So on average, like if we say that 1 pint of blood has been taken, so it means that you have like 470 ml of the blood. And then if the blood is stored at 4 degrees centigrade, and the blood can stay in the lab for like 5 weeks. And then after 5 weeks, 70% of the RBCs, they will be viable, they will be good. Whole blood is very rarely used. And mostly, how do we use it? We take out the packed RBCs. And that is used, okay? So the packed RBCs, what we do here, why we call them packed RBCs? Because the plasma has been removed and replaced by optimal addition of the solutions which will contain glucose, adenine, mannitol, and the sodium chloride. and the blood is passed through the leukocyte depletion um, deleter, because we want that the blood should have no WBCs. So that is the point. And if you will give like 1 pint of blood, then the hemoglobin of the patient, it should increase by 1 to 2 grams. Okay, that is the point. So the washed RBCs, they are used in the patients who have an anaphylaxis reaction or who has the tendency to develop urticaria. Platelet concentrates, they are also prepared from the whole blood, and the platelets, they are stored at 22 degrees centigrade, and the problem is that platelets, they can be stored only for 5 days. So we have to give them fresh platelets, because the half-life of the platelets is just 10 days. So if they are broken down, then they will not have their function. Then the fresh frozen plasma, it is also taken out from the blood, and it is taken from the plasma, and it is stored at like minus 30 degrees centigrade within 6 hours of donation. So usually 1 unit of the fresh frozen plasma means that we have 200 ml of the plasma, and it is given when your patient has like bleeding disorder, clotting disorder, or patient has gone into DIC, then we will have to give fresh frozen plasma. Cryoprecipitate, what happens that fresh frozen plasma is taken from a single person who has given this donation, and then it is thawed like at 4 to 8 degrees centigrade, and then the volume which is above that point, like it is like 20 ml, then it is taken out and then again stored at minus 30 degrees centigrade. When the blood will clot, it will form, what will happen, this cryoprecipitate, it will ooze out and we will collect it. And this cryoprecipitate, it contains factor 8, and then it contains von Willebrand factor, and it also contains fibrinogen. So the cryoprecipitate is also used in the treatment of disseminated intravascular coagulation when your patient is bleeding, and then to stop this process of bleeding, like there is site of IV cannula and there is oozing. So to prevent this type of bleeding, we will have to give cryoprecipitate. Even in the cases of postpartum hemorrhage, antepartum hemorrhage, we can give this cryoprecipitate. So then the second type, factor 8 and factor 9 concentrates. They can be synthetic or they may be collected from the pool of the plasma. So the recombinant factors which are formed artificially, they are the treatment of choice for inherited bleeding disorders, because the risk of infection and other things, they can be decreased. So those which are formed, or the recombinant one, they are better for transfusion in cases of bleeding disorders. Regarding blood use in the emergencies, so in such conditions, what we have to do, like there is shock, patient is in shock, you have given crystallites, patient is not improving, colloids not improving, so you need to give blood immediately. So you can use 2 units of Rh negative or O blood group, which is Rh negative, universal donor. In each hospital where they are carrying out the major surgical procedures, it is a pre-requirement that they should have blood bank, and in the blood bank at any time 5 units of O negative blood should be available. So if the blood is required, then it should be given within 10 to 15 minutes, and then type specific blood should be given. Like if you cannot wait for 1 minute, your patient is bleeding so much that you think that patient is going to collapse, then immediately give 2 units of ORH negative blood. But if you think that your patient is losing blood at a rate when we can give her blood within 10 to 15 minutes, then you should give group specific blood, like the same ABO blood group and the RH type. If you think that patient requires blood in 45 to 60 minutes, in that case, you can use cross-match blood. Cross-match blood where they are 100% sure that no hemolysis will not take place. So if you can wait for 45 minutes to 1 hour, then you should go for cross-match blood. Now, all of the procedures, they have their complications. So what are the complications of blood transfusion? There can be immunological reactions, and the non-immunological reactions. If we talk about the immunological reactions, then you should know that there can be alloimmunization, like patient can form antigens which are present on the RBCs, platelets, leukocytes, plasma, and this is not a problem with the first transfusion. But when your patient is taking repeated transfusions, then there is risk of alloimmunization, and alloimmunization, it can be due to ABO blood group also. And these atypical antibodies, though they are of the same blood group, but due to repeated transfusion, mother can have antibodies against this ABO system. And then these ABO antibodies, we have read that they can also attack the RBCs of the fetus, and they can cause hemolytic disease of the newborn. That is important, okay, especially type C and K. Then when we are giving the blood and it is incompatible, then hemolytic transfusion reaction, they will take place, and it is associated with like rigors. Patient can have loin pain in the renal angle. There can be shortness of the breath, and then there can be hypotension, there can be hemoglobinuria, and there can be renal failure and disseminated intravascular coagulation. Sometimes you have given blood, then at the time of blood transfusion, patient didn't have any reaction, but 1 week after that, after transfusion, patient became pale, developed anemia, and or had brownish urine. So this is delayed transfusion reaction. Then sometimes you must have seen that when you are transfusing blood, your patient will develop fever. So this is non-hemolytic febrile reaction, and it may be due to leukocyte antibodies. And what will happen? Patient will have flushing, fever, tachycardia, and rigors. So in that case, if the giving the blood is very important, you don't have to stop blood transfusion, but you will slow down the rate of blood transfusion. If your patient has urticaria or anaphylaxis, then what you can do is, like patient has severe skin itching, in that case you can stop blood transfusion, and then what you can do, or you can slow it down, and then what you can do is that you will give antihistamine to the patient, like you can give them injection phenyramine. So severe anaphylaxis usually doesn't occur. Then the non-immunological risks of blood transfusion. Obviously, the most common is risk of transmission of infection, and among the most common infections, you can say hepatitis B and C. HIV can occur, but that will not be the most common reaction, okay, like it can occur. So the risk of transfusion, and then other problems can be that there can be a risk of bacterial infection, and then if there is, we have given that blood which is contaminated with bacteria, then you can understand that we can cause septicemia and death of the patient. Then the peons, they can be passed like the Creutzfeldt-Jakob syndrome. Then the patient can have volume overload. We call these things TACO, that is transfusion associated complications in the body. Okay, so these are fluid overload, acute lung injury, acute renal shutdown. These complications can take place. Transfusion related acute injuries in the body. Okay, then these patients, they can have like changes in the oxygen carrying capacity of the blood also. Okay? Then these patients, after massive transfusion, they can develop hypocalcemia. So that's why, once you have transfused like 4 units of blood, then you will have to give 10 milligram, 10 ml of 10% calcium gluconate also. Otherwise, your patient will have some toxicity reaction and hypocalcemia. Hyperkalemia can occur because in the blood, when the cells are like broken down, then there can be excessive potassium. So the potassium content of the stored blood, it will increase, and it will cause some reaction. So that's why, that is also one of the complications. Then hypothermia, that if you are transfusing blood which is not at normal body temperature, then your patient can go into shock also. So that's why, if you have to give blood in cases of PPH, then you have to give warm blood. And if this blood is poor, then it can cause even heart attack, myocardial infarction, and it can cause hypothermic shock also. So these are the important aspects of blood transfusion. So with that, we have reached the end, and I hope that it must have answered many of your questions. But still, if there is any problem, please feel free to ask me.